Sir, please start.
Rajesh, Vinayak sir, you want to start?
Sir, no, he is ready. Rajesh, you can start, no problem.
Okay.
Yes.
All right. So thank you, Maha IP, for giving this opportunity to me. And last three sessions have been awesome. Patki sir has really presented very difficult cases and very well managed cases. And I hope I am able to do justice to this program really. So today we'll be having one case. This one case is quite interesting case. And
Rajesh,
today we have, yeah.
Before you start, I'll just welcome everyone.
Sure, yeah, please.
Okay. Good evening, friends, and welcome to the Maha IP platform, another series of Casebook Live. As you know, it's a different concept designed by our scientific convener and very well supported by Dr. Vinayak Patki and Dr. Rajesh Kulkarni. Here we would be having a case which is not known by anyone, nor the experts, nor the PG student. And rather than the diagnosis, the approach towards the case is important. So we would be discussing at each and every step. So today, Dr. Rajesh Kulkarni from Pune, he would be presenting the case. And for the I welcome today's experts, Dr. Vibhor Borkar, Dr. Prachi Karnik, and Dr. Sarita Kokani. We have a PG students with us. Welcome, Dr. Veena Mugli and Dr. Manan Salodkar, and their mentor, Dr. Manish Tiwari. So welcome you all, and I will not take much time. We'll start with directly with the case presentation. Over to you, Rajesh.
Great. Thank you, Dr. Ram. So I'll just share my screen. Okay, is the screen visible?
Yeah.
Okay, so we'll get started. So all the best, Team GMC Nagpur.
Only thing is, Rajesh, your picture is not very clear.
Okay. Okay, I think for time being, let us
okay.
Be with it, and we'll start the case. Okay.
Okay.
So all the best, Team GMC. I'm sure you are well prepared. Although this case is known only to me. So I must say that, we are, as Dr. Ram has said, we are not trying to reach a diagnosis here. Instead, we want to know how you approach symptoms, examination findings, some of the investigations that we have done, and then try and reach at least a syndromic diagnosis or try and reach at least a systemic diagnosis with likely etiology. That is our aim, really. So let us start. So this is a 2-year-old boy, and he was born of a non-consanguineous marriage belonging to Baud community. And his chief complaints are abdominal distension for 2 months, black colored stools 3 weeks back, and fever off and on since the last 2 weeks. So these are the three symptoms with which the child has presented, really. So I'll just go into the details of the history. This child was apparently all right 2 months back when the mother noticed that there is an abdominal distension. This abdominal distension was insidious onset. It was gradually progressive, and the mother specifically said that this abdominal distension was more noticeable in the upper abdomen. This abdominal distension was not associated with any fever, abdominal pain, vomiting, any rash, any yellowish discoloration of eyes, any other bladder bowel disturbances, no drug intake, no cardiac symptoms, no paleness of body, no bleeding. So this was an isolated symptom of upper abdominal distension which was there, which the mother has noticed. So what the mother did was she took this child to a nearby doctor, and he examined the child and he declared that the child is quite all right and the examination is normal. And he told the mother there is no need to worry about the child. So at this point, no investigations were done and no medication was started. However, this child, before he was admitted to us, 3 weeks before the admission, he started having these black tarry stools, which were sticky, foul smelling. They were moderate volume, 4 to 5 episodes per day. It lasted for only 48 hours, only 2 days, and after that it subsided. And the mother was not very worried about this symptom because there was no abdominal pain, there was no fever, and the child was otherwise all right. And this subsided on its own, so she did not consult any doctor. Next, the child started having fever. Now, this fever was from 2 weeks. It was an on and off type of fever, insidious in onset. The spikes were recorded up to 101, 102 degree Fahrenheit. These were intermittent spikes, and these would easily respond to paracetamol. The child was quite active, playful, alert in between the fever spikes. And typically, the spikes would be 1 or 2 spikes in a day, in every 2 to 3 days. And this was going on for the last 2 weeks. Initially, this fever was associated with some mild cold and cough, which subsided after 3 days, but the fever did not subside. So the fever continued. This fever pattern you can see here. This was actually the fever pattern what we observed in our ward. But mother says that the fever pattern was very similar, where the child would get a fever of 101, 102, and then it would stay there for a day or two. Then it would subside completely for 2 days. Again, the child would have a fever spike. Again, 3 days gap. Again, a fever. And later on in the ward, the child had no fever for the last 7, 8 days of admission. However, for 2 weeks before admission, the child was having this pattern of fever. The fever was not associated with any joint pain, rash, vomiting, loose stools. There was no jaundice at all. There was no altered sensorium. There was no increase in abdominal distension, and there was no melena this time. There was no black colored stools really this time. So these are the symptoms which are there, and I want to know from the PG residents what they think about this really. Hello, Dr. Manan? Yeah.
PGs, unmute yourself. Yeah.
So we have missed last couple sentences, sir. We were offline.
Okay, so you want me to show the slides again? I will just show you the slides. So these are the symptoms.
Huh.
3 symptoms that are there. The first symptom was that abdominal distension, which is there for nearly 2 months and which is progressive. The second symptom was melena, which was about 3 weeks back and which lasted only for 2 days. And there were no other symptoms with melena. And the third symptom is fever, which is there for 2 weeks. And this is an insidious onset fever, but intermittent fever. In between, the child is well. The child is only unwell during the fever spikes. Otherwise, the child remains well. And there is no other associated symptoms with the fever. So it apparently is without localization for 2 weeks. And this is the pattern of the fever. So based on this, what is your thoughts on this case so far?
The patient presented with abdominal distension more in the upper part of abdomen. So we can consider it like might be hepatic in origin, one of the possibilities. And it is also associated with melena. Melena is some bleeding tendency from the upper GI tract. So it can be associated with, can have something to do with the stomach as well, because both are in the upper abdomen. And later the child developed high grade. Now there were things which go against liver are basically there is no icterus, there is no vomiting, there is no other than distension of abdomen. There are no other signs suggestive of hepatic etiology.
It is
What about melena
yes,
in a
like-
liver disease? Don't you think melena can be a liver
Yes, sir.
disease?
Melena points towards can be because of coagulant disorder, defect in synthesis of synthetic function of liver.
So, but before that, we would have at least got jaundice, yeah, any other clinical manifestation of early hepatic failure rather than direct melena. So, and this initially rules out infective etiology because the patient didn't start with fever. The complaint started with hepatic origin. Later, the child ended with having fever.
Why do you think this is hepatic origin? What symptoms this child had tells you that this is hepatic origin? After all, hepatomegaly is not liver
Sir-
disease always.
So mainly the pointer was distension of the abdomen in the upper abdomen, more likely to be liver in origin, sir. And it was initially the child was not having any acute symptoms of any fever, pain in abdomen, or it wasn't gaining any medical attention. So less likely any infective or acute cause causing abdominal distension.
Okay, so both of you feel that this has to be a liver disease. It cannot be other etiology at all for the upper abdominal distension, the melena, and the fever. You think that this is a liver disease. That is what you're thinking. Any other alternatives you think in this child? I know we have two gastroenterologists and one hematologist. So you are thinking of liver disease. But suppose they were not there, what would be the other differential diagnosis that we would have?
We could have thought of portal hypertension, but there is no ascites, no distended veins, no variceal bleeding.
So we don't know about distended veins yet. We have not examined the child yet. We also don't know about ascites. We are still on history.
So portal hypertension usually does not present directly as an abdominal distension, sir. Initial symptoms will be either the child will have having hematemesis or some other condition rather can be.
So it can be portal hypertension as well, can be hepatic in origin.
Okay. So now at this point, I would like the experts to come in. And Dr. Vibhor, sir, your thoughts on this, and Dr. Prachi, ma'am.
Hi, good evening, everybody. Am I audible, right?
Yeah, you're audible, sir.
So, this child has three components. One is abdominal distension, black tarry stool, and fever. So, most objective, probably, the complaint here is melena. Okay, they are very clear that is the melena. So, melena means there is a large volume bleeding, GI bleeding. This is very important. Now, important is for PG students, just one question to you. How will you approach a child with large volume bleeding? Then other fever, abdominal distension, other things will keep into the associated symptoms. So either Veena or Manan, any one of you can answer. The approach to child with large bleeding.
So first, if the patient has large volume bleeding, the local trauma or any local injury will be ruled out, sir. Then the other causes of bleeding. Then the other causes of bleeding manifestations will be taken into consideration based on the associated symptoms.
One of these can be coagulopathy as well, but coagulopathy requires other features as well, like hemarthrosis, hematemesis, deep-seated hematomas. There's no bleeding manifestation other than melena, which was transient.
Yeah, so how will you approach? There is a melena, that is the objective thing you have. Okay, so if you have a coagulopathy, of course, the vitamin K deficiency can present as a GI bleed, but you do have some ecchymosis and other things. Isolated GI can be possible. I'm not saying it's not, but then you have to consider the the liver and the portal hypertension. They sometimes go hand in hand. You cannot basically have a clear-cut borderline between them. So, can be coagulopathy, it can be portal hypertension. In fact, in the presence of coagulopathy, portal hypertension, bleed, and mortality related exactly into this. So, that means let's cut short it. So, if you have a child with a large volume bleed, we have to basically see that what kind of associated symptom are there. There is a pain in abdomen or not. Now, sir, Rajesh, sir, do you think the child is having a pain in abdomen? Is a 2 years child. The symptoms
may
be limited.
So during the admission, this child never had any abdominal pain as such.
Melena episode.
No abdominal pain.
Yeah. So it becomes a painless upper GI bleed. Now, when you have a painless upper GI bleed, again, two possibilities. Either is a liver related, which can be portal hypertension plus coagulopathy. And the third possibility is, are you dealing with any vascular malformation? These are the possibilities. Okay. Now, further differentiation between this component will be depending on the examination. Suppose this abdominal distension is static, for example, is an organomegaly. Then this is more likely to be a portal hypertension. Suppose there is no organomegaly, then it is more likely to be a vascular malformation. It can be arterial vascular malformation in the stomach, which can have a brisk bleeding and it stops. Now, coming to the previous arm, if there is a pain in abdomen is present, then we think of a peptic ulcer injury to the gastric and upper duodenal mucosa. So that can be because of a gastric ulcer or some NSAID is given. Sometimes they go to any doctor and they just give some, they don't know the medicine, they don't have a prescription. There is no way you can have a history. So it can be a medication induced also. So that's how I will go, sir. Yeah.
Right.
So here,
Dr. Prachi, madam, what are your thoughts on this?
Yeah, so if we go strictly by the chronology, although as Dr. Vibhor rightly said, the objective thing here is bleeding. But if we kind of go by the chronology where the abdominal distension is a very significant and a very persistent complaint. So abdominal distension, what we have learned always over the years about the 5-6 Fs, of which in pediatrics, what we consider important is fluid, organomegaly, and so basically these are the two which are the most important, out of which, since you're saying that it is the upper abdomen and that it is a gradually progressive thing, I would here put the organomegaly more first as compared to the fluid at this point of time, although later we might expect some fluid to come up. The third thing in pediatrics important for abdominal distension is intestinal obstruction. But with the beautiful history that Dr. Rajesh has given, this does not look like an obstruction. There was no obstructive symptoms either of acute or subacute obstruction. So if we consider this probably could be an organomegaly. Now on that background, when we come to the bleeding, so as Dr. Vibhor had said, there are two strong possibilities with the organomegaly. One is a coagulopathy and the other is a portal hypertension. With coagulopathy, I would expect if this is a chronic liver disease with coagulopathy, the child should be a little more sicker, especially during that episode of the GI bleed. There should have been some decompensation. But here in your history, Dr. Rajesh, there has been, clearly you've mentioned that this child has been active, alert, playful. And so I would not expect this to be a coagulopathy. I would put more of a portal hypertension here. And then if we come to the fever after that, now as we all know, fever, there are 2-3 possibilities in pediatrics: an infective etiology, an inflammatory etiology, maybe lower down a malignancy. Again, with infection, it could something like, say, a portal hypertension with ascites with SBP, the child would be sicker. So I wouldn't right now keep that. It could be some other superadded infection going on for 2 weeks in our setup. Definitely COX should be considered, but that will be a separate limb. So if we were to put it all together with a long history of 3 months of abdominal distension, organomegaly, and now fever, it could be an inflammatory etiology. So that is my, a stronger take here. More than infection, it could be inflammatory. Malignancy, maybe yes, a little lower down the list. So at this point, strongest possibility would be a chronic liver disease of some inflammatory pathology with a portal hypertension, but not decompensated at this point of time. So a compensated liver disease.
Right. Okay. So Dr. Sarita, madam, I am going to come to you in a minute. So we'll just go to the next slide. Now this child, his fever was persistent. So the mother got concerned and she took the child to a hospital. This child was admitted for 3 days. There they gave him some IV fluids, IV antibiotics, some blood tests were done, an ultrasound abdomen was done. They found that the child is quite pale and the child's hemoglobin was low. So they gave a PCV transfusion. And after that, they referred the child. So this child came to us after a blood transfusion and the child had documented fever in the hospital. So there was no significant past history, no significant family history. Antenatal, perinatal period was okay. There was no significant birth history. The child was breastfed for 6 months, no NICU stay, immunized completely for his age. He was 200 calories deficient, 4 grams proteins deficient. He was developmentally very appropriate for his age. So no clues here. So this is the set of investigations that were done in the lab that was outside lab. This was before the child was referred to us and before the child received a blood transfusion really. So I would request the PG students to interpret the hematology part of this first. So can you please interpret this for me?
Yes. Sir, our screen is going blank repeatedly, sir.
You cannot see the investigation.
Can you see, or I will read it? It is not a problem. Shall I read the investigations for you?
So we'll try to join, sir, with.
Okay, I'll read out the investigations, not a problem. Okay. So the hemoglobin was 3.3 grams per deciliter, and the WBC was 10,600, of which 40 were polymorphs. The platelet count was normal, it was 2.6 lakhs. The MCV was low, 65, and the MCHC was low. The RDW was 23%, okay, which is on the higher side. The RBC count was 1.76 million per cubic millimeter. And the peripheral smear showed poikilocytosis, teardrop cells, schistocytes, target cells, 8% NRBCs, and reduced erythron. The ferritin was high, 121 nanogram per ml. The retic count was 3.4%, and the corrected retic was 0.86. They also did an IRF, immature reticulocyte fraction, which was 9.4%. They did a retic hemoglobin, which was on the lower side. LDH was on the higher side. B12 was normal. So far, this is the hematological part of the investigations, and I would like your opinion on what you feel on this hematological investigations that were done. What is your interpretation?
You can go step by step, Dr. resident's name I just missed. So just go step by
Dr.
step.
Manan.
Yeah, Dr. Manan. So go just step by step. First, look at one parameter grossly. First, see what it is. So what about the hemoglobin?
You
Hello,
will need to unmute yourself. Dr. Manan, you need to unmute yourself, please.
Dr. Manan, and
Sir,
who's the other resident? Yeah,
Veena.
Dr. Veena.
Am I audible, ma'am?
Yes, ma'am. So just look at the red things that Dr. Rajesh sir has made the thing quite easy for you. Look at the red things first. What do you feel from the hemoglobin? Very obvious. Am I audible, Rajesh sir?
Yeah, you are audible.
We have audio and video issues, sir.
We can hear you now. You can stop your video. That is all right. I think that will improve your connection. Yeah.
So the hemoglobin is 3.3. The child is having severe anemia. But symptomatically, the child is not decompensated as such.
Okay. What about the other values that you are?
The TLC and platelet counts are quite normal for CBC here. The MCV is on lower side. 65.5 is quite low for the age. And
Yes.
so is
RDW is on the higher side. 23.
Okay. Yes.
And the RBC count is also low.
Yes.
Okay.
With the teardrop cells and schistocytes on peripheral smear and target cells as well. So hemolytic picture here, sir. There's a slight hemolytic picture here.
Yes.
Okay.
Increase in ferritin. Ferritin is on a higher side and LDH is also on higher side, sir. Which may be indicative of
Rajesh, unmute
inflammation.
yourself.
I'm unmute actually.
Increased ferritin and LDH is indicative of inflammatory etiology also, sir. There must be some inflammation ongoing.
Okay.
The reticulocyte hemoglobin is 15.9 and reticulocyte hemoglobin is quite an early marker of anemia. It is said. So
Which anemia, Manan?
iron deficiency anemia.
Yeah.
So the child must have been chronically anemic and must have had further anemia, matlab further drop in hemoglobin due to this current issue, Malina?
The more pointer towards iron deficiency anemia was increase in RDW along with the low reticulocyte hemoglobin. So both strongly points towards either iron deficiency anemia or anemia.
Besides the LFT, the transaminases are also raised, but they are not grossly deranged to call it hepatitis. They're
We
all
will go to the liver part, the liver function test later. Right now, I want you to focus really on the hematology part. So you rightly said that this is anemia. You rightly said that there is a low MCV, MCHC. The RDW is high. So this looks like iron deficiency to you, nutritional anemia to you. Okay. What about the RBC count in an supposedly deficiency anemia, iron deficiency anemia? Is a low RBC count in keeping with the iron deficiency?
No, sir. Normally we have raised RBC count. No, in thalassemia.
reduced RBC count is more in favor of some hemolytic etiology.
Would the bone marrow not compensate? Would the bone marrow not compensate in a thalassemia? Do you think they have low RBC count?
So,
That will have
in thalassemia we have increased RBC count, sir. So
Yeah, so here you have a low RBC count, okay, and you have a corrected retic count which is also on the lower side,
so
and we have a low IRF and a low
Issue-
retic hemoglobin.
issue itself is in the bone marrow, so probably that must also be a condition. Where
Okay, Dr. Sarita madam, your inputs on these tests?
Yeah. So, see, clearly we are dealing with a microcytic hypochromic anemia with a wide RDW, low RBC count, and a low reticulocyte count. The RDW, 23%, what you have to remember is, see, your iron deficiency does lead to a wide RDW, but usually not more than 20, okay? Whenever you get a RDW which has crossed 20, think of multiple things going on, especially, when you have an ongoing hemolysis due to any other reason, you will have, in fact, a wider RDW. Just like if you see in this peripheral smear, the description itself says there are schistocytes. Ultimately, they are what? Broken cells, right? So the smallest cell is like a broken cell. To the largest cell on the peripheral smear described here is an NRBC. So just look at the anisocytosis that is there. It is not attributable to alone iron deficiency. This is what RDW is telling us, one thing. The low RBC count here tells that the marrow is not able to compensate adequately. Okay, so the relative compensation, if you look at what is expected at a hemoglobin of 3.3, is not being done by the bone marrow. So whether primarily bone marrow or secondary due to some other chronic inflammation going on, the bone marrow is definitely suppressed considering the RBC cell line at least. All right. So I think in this scenario, we are looking for the etiology of anemia being multifactorial. So maybe it is, some amount of, at 2 years, some amount of nutritional iron plus B12 deficiency going on, some amount of anemia of chronic disease going on, and this acute hemolysis could be a part of just maybe some autoimmune hemolysis happened during this febrile episode which was going on. So here in this scenario, when you have something not fitting in alone, I would consider, in fact, multiple etiologies for this anemia right now.
What about bleeding as a cause of this low hemoglobin? In addition to the nutritional anemia, would
Yeah,
a bleed, for example, a melina, would that be
contribute.
consistent with this picture?
Alone melina does not look like, because your anemia. Suppose the hemoglobin pre-melina was appropriate for the age 11, I would have expected a normocytic normochromic anemia rather than such a microcytic with that much wide RDW. Okay, so if it was alone melina contributing to a hemoglobin of 3.3, plus the child would be even more sicker, must have gone in failure by now at a hemoglobin of 3.3. But hematological parameter wise also, alone melina contributing to this anemia looks less likely. Definitely some amount of contribution from the melina might be there, but this 3.3 is a multifactorial, I would consider here.
Perfect. So now that we have, an hematologist's opinion on this, and the students, what do you think? So is this a hemat case now? Have we changed to a hemat case? So now I have probably, I would say, an organomegaly, maybe an hepatosplenomegaly with severe anemia, requiring a blood transfusion, a hypoproliferative marrow. So has this changed now? Is there a liver disease or there is no liver disease? What are your thoughts now?
So there is an underlying component of hematological issue here because the picture is mixed. But
Okay, so
but
what
then there
about a primary hematological problem? I am saying there is no liver problem at all. This seems to be more of an hematological problem.
It can be a condition, sir, where there is any storage disease causing bone marrow infiltration and the liver infiltration.
Then why is the WBC count normal? Why is the platelet count normal? You have only one cell line affection here. Isn't it? So this is not, definitely not something like a malignancy which is infiltrating or the storage which is infiltrating the bone marrow, is what I would think. Okay, now quickly let us go to the liver function test and tell me what you see in the liver function test.
So the transaminases are elevated. They're more than 3 to 5 times the normal range.
What are you worried more about, the SGOT or the SGPT? What are you worried about?
The SGOT is non-specific for liver, like it has multiple sources, and SGOT is more elevated than liver-specific SGPT.
Okay, so this is consistent with some hemolysis going on, some anemia going on, isn't it? The SGOT being high. SGPT is not so bad, isn't it? What about the other tests?
So the bilirubin here is normal, and the albumin levels are less than 3, sort of a little towards chronicity.
Could be nutritional.
Could be nutritional, sir. The
Okay.
bilirubin is such normal, so the excretory function of the liver is well preserved, and bilirubin is normal. Alkaline phosphatase is 156.
So what does that indicate? Is it helpful? It's not very elevated, isn't it?
No, not very contributory.
Okay, so can I ask Dr. Vibhor again?
Yeah, hi.
So in the light of the clinical history that we had, we have this hematology and liver function test that we have. So can you please interpret, and later on I would come to Prachi ma'am and ask her if any other investigations you would have done at this point.
So here we have SGOT more than SGPT. Now this can be one, the source can be even the RBC lysis. They can also contribute to the SGOT. Even a little bit of SGPT can go up. So this contribution is extra hepatic source. That is one possibility. Another possibility is definitely a chronic liver disease. In that also SGOT is more than SGPT. So two possibilities over here. Now coming to organomegaly with fever going on, inflammation going on. So are we dealing with an infiltrative disorder with some maybe a hematological angle to it? So in such scenario, generally your alkaline phosphatase is elevated. Even alkaline phosphatase also comes from RBC. So it's very odd that your alkaline phosphatase is not elevated. So I'll come to that point. Here we also need GGT. Now remember, in pediatrics, when you're ordering liver function test, GGT should be the part of LFT. If your lab is not including request them, or you mentioned as a separately. So alkaline phosphatase and GGT should come together, because alkaline phosphatase has many fallacies. For example, this child is suppose nutritionally not well. He has a zinc deficiency. Alkaline phosphatase may be low. Okay, so that is another fund. So that may be the fallacy of alkaline phosphatase. So we'll need a GGT over here. Now coming to the total protein and albumin. So if there is a massive GI bleed, sometimes in an acute phase, we do get low protein and low albumin because it is an entire volume has lost. So we don't have a pre-illness one. So, and we have not seen the patient yet. So I will keep both the possibilities. It can be a chronic liver disease. Even the low albumin is a inflammatory because a marker of an inflammation. Ferritin, low albumin. So even that possibility we'll have to keep. Another aspect is INR should be also a part of a liver function test, specifically in this child when the child has came with the bleeding. Has this child received FFP also outside or only?
No, this child only received a PRBC. No FFP was given, and gamma GT and INR was not done
Okay.
outside.
Okay.
Actually, this child went to a hematologist. So,
I will, can I
questions
interfere? Can
can
I
be-
also suggest a test?
Please, yeah. Yes, yes.
Yeah. So if the
Yeah.
alkaline phosphate would have been high and GGT would have been high, I would have gone more. This would have gone towards an infiltrative. Yeah. Here, probably definitely RBC lysis is contributing to it. Low albumin has, I will say, three components. One can be a chronic inflammation, one can be a liver disease, one can be the GI loss. Okay, and INR and GGT we want.
Great. Prachi ma'am, anything else you want on the liver part?
So I was going to suggest GGT and INR, but I think Vibhor has covered that.
Right.
Means as far as blood investigations are considered, I think we are quite good. We will, I think, come to the radiological and other investigations. I presume you will be showing us.
What about gamma GT? Generally, our training is that unless there is a conjugated hyperbilirubinemia, which means there is some obstruction which is happening, would a gamma GT really help?
So gamma GT is basically produced by the cholangiocytes. So any injury to the cholangiocytes, also any inflammatory pathology of the cholangiocytes in the absence of a cholestasis also in the initial phases can have an elevated GGT. So Vibhor
Right.
has rightly said that only ALK-Phos is not enough for us, and we definitely want to have a GGT. And INR, if it is deranged, then I would want to know post vitamin K, if somebody has given a vitamin K, whether it has been corrected after the vitamin K and how much is the correction.
Right. Okay. So an HPLC was done, and that has not
Dr.
shown any.
Rajesh sir, Can
Yeah.
I? Yeah.
Yeah, please.
So,
Yeah, please.
in this scenario, one very inexpensive test that can just give a clue in a very early stage is your DCT ICT. Okay, especially when your HPLC was already normal. I know there is no indirect hyperbilirubinemia yet, but with some hemolysis going on and SGPT, SGOT not conclusive of a liver disease, DCT ICT is one test at this point itself I would have asked for. Okay. Yeah.
Correct. So gamma GT was done and that was normal. Okay, we'll come to PTINR a little later. And DCT ICT was done, that was negative. So these were done in our hospital later on. So now let's go to the next slide. So an ultrasound was also done. Before the child was referred to us, they did an ultrasound and that just showed some mild splenomegaly, gallbladder wall edema, some ascites, and otherwise it was all right. So not much contributory. So here they are saying liver is normal in size, shape, and echogenicity. Again, Dr. Vibhor, comments on this ultrasound?
So in pediatric ultrasounds, normal has no meaning. There has to be mentioned about sizes. So please request your radiologist. This normal may be for an adult. We never know. So ask them the liver size, ask them the spleen size. They have mentioned spleen size. I'm very happy. Gallbladder also ask them the sizes. It may not be relevant in this age group, but suppose some obstructive pathology is there which causing vitamin K deficiency. The gallbladder is hugely distended. That you go towards that. So that way, even a right kidney normal, left kidney normal in size. This child can be having like maybe a tyrosinemia with one. So if the big size kidney will give a clue. So lot of clues one can get from an ultrasound. So please request your radiologist to mention the sizes, not the normal.
Point well taken. So let us go to the next slide. And this is in
Rajesh,
brief. Yeah, sure. Yeah.
I'll just go back one slide when you asked us what more investigations. I think
Yeah.
since here we are looking at the liver involvement as well as hematological, so more than one system, we would need the other systems also, particularly renal, and also the RFTs would help
Yeah.
us.
So the RFTs were done and they were normal because of the space constraint. I did not project it.
Right.
But the RFTs were normal. Uric acid, BUN, creatinine, all the other tests were quite within normal limits.
Right. And other thing was, of course, the anemia will now be a confounding factor, but ESR might help us with the inflammatory pathology.
Yes.
It
Yeah.
might be difficult to interpret. And since
Correct.
the albumin is very low, globulins are around 3, I think 3 odd. An immunoglobulin G level might help us here if we are strongly considering an autoimmune liver pathology.
Yeah, IgG. So that was not done before referral to us. And so this is in brief the timeline that there was abdominal distension, some melena, fever, and received a blood transfusion. So far we know this is what the child had. So in summary, would the PGs like to summarize, just a quick summary before we go to the examination part? What do you think so far?
The child is a 2-year-old toddler, male toddler, who presented with abdominal distension of 2 months, black stools, melena, intermittent transiently, with a history of on and off fever, intermittent fever since 2 weeks, which was high grade as per the history and documentation. And in view of certain lab investigations and clinically he was pale, he received one packed red cell previously and was referred to us. His labs were suggestive of mixed picture in the form of microcytic hypochromic anemia with some changes suggestive of hemolysis ongoing as well, might be due to acute blood loss, changes of hemolysis, and depressed red cell line.
And with raised inflammatory markers, and there was no any significant contributing family history or past history, or there was no other any bleeding manifestations other than melena.
So liver disease or hematological problem? What is your verdict? Or could be both. It's like asking NDA or India. Isn't it? Right now we don't know. So we thought, this is, we have enumerated the symptoms. So a chronic progressive acquired disorder with some upper abdominal distension, maybe an organomegaly. And we don't know whether it is a hematological problem yet or a liver problem yet. We are not very sure about it. So what would be the differentials in your liver pathology B? What would be your differentials in hematological B? Starting with the liver disease, what would cause a liver disease like this? For the PGs, which liver diseases would come with an organomegaly, severe anemia, maybe a melena, and fever?
Liver hemangioma can also present like this, sir.
Hemangioma coming with a GI bleed, fever. Dr. Prachi ma'am, what is your thoughts?
Hemangioma coming with a GI bleed is very, very unlikely. So that I would not consider. I would still stick to the inflammatory pathology and an infiltrative disorder at this point of time.
What about infection? Would an infection be possible?
Hemangioma lead to altered LFTs, Dr. Prachi ma'am?
No, we wouldn't expect that.
Right. So hemangioma is a localized there. I mean, I don't think it leads to SGPT, SGOT elevation.
Exactly. So unless there is bleeding, you wouldn't get this severe anemia either.
So hemangioma, they won't cause so it is causing a melena. No, it's a bleeding beyond that lesion. So that won't be possible. So hemangioma is it's out of question. Only SGOT, SGOT elevation it will give if there is any hemolysis or platelet consumption is going on in a large hemangioma. This is very rare and child will be very symptomatic. So these are the rare cases. In this situation, we should not keep the possibility of hemangioma.
So we should keep a possibility of some infiltrative disease, some inflammatory disease. What about an infectious disease in the liver? Some chronic infection, some unusual viruses. Because there is organomegaly, the child has low hemoglobin. Maybe a chronic liver disease because of a chronic hepatotropic virus. What are your thoughts, Dr. Vibhor?
Yeah, right. So, so the chronic viruses like B and C, which are we call as a classical hepatotropic viruses, they do not become symptomatic. C, absolutely out of question. B, if you have 100, less than 1% will go to the cirrhosis. So very, very unlikely. Now the other hepatotropic viruses are we dealing with this infectious mononucleosis because there is a initially an organomegaly, some low-grade fever, hepatomegaly, splenomegaly, some bone marrow issues and all. Yes, one EBV infectious mononucleosis, but might be there. But liver, the spleen would have been. I would have expected a little bit larger spleen over there, but I think that won't rule it out. So that is the one. Again, another thing is the CMV. Apart from that, chronic viral less likely. Another possibility, if for example the disseminated tuberculosis and all, yes, possible. But again, they're giving the IV hemolysis and all, that doesn't fit. Third possibility, it might be an autoimmune liver disease along with the autoimmune hemolytic anemia that goes quite up over here. Then infiltrative disorder with bone marrow infiltration, but other things like CBC, WBC and platelets are normal, only isolated HB. Otherwise, Langerhans cell histiocytosis, again, it have been that we should keep at 2 years when they are hepatosplenomegaly and the low albumin, some fever going on. So I think this broad one I will keep. Very rarely histoplasmosis of the liver. Very, very rare. We don't see it here, but sometimes just possible in an immunocompetent patient also can see. They are seen somewhere from the patient from the Bangladesh. All they are seen. Apart from that, I don't think anything is striking right now. Yeah.
Right. Dr. Prachi, what about the metabolic liver disease? Why is this not a tyrosinemia?
Yeah, sorry, I missed that. Tyrosinemia is again one possibility, but again, the hemolysis going on is a little bit odd in the tyrosinemia. Sorry. Yeah, please continue.
What about storage? Dr. Prachi, I would like to ask you, what about a storage disease here?
Again, in storage, actually, portal hypertension is not very common and definitely not in a child who is 2 years old. So here, definitely with the bleeding, we are expecting that there is some portal hypertension. So I wouldn't keep that. And as we looked at the CBC also, we are looking more at a hemolytic cause of the anemia. The other two cell lines being normal, we are not looking at a bone marrow infiltration and suppression here. So that's why storage. Another thing is, if you look at storage with portal hypertension, one condition that comes up is GSD type 4, which is the storage disorder which does present with portal hypertension. But I think this is a little early for portal hypertension to present even in GSD type 4.
Okay. Apart from tyrosinemia, which other inborn errors would you look out for at this age in a 2-year-old?
Mitochondrial can present at any age, but there should have been some history in the newborn period, in the infancy of some illnesses recurrent. So I don't think that at this point of time.
Right.
Tyrosinemia, of course, is one which comes at any age. It can present at multiple. Late presentation of tyrosinemia is also known. So that would
Right.
be considered.
Other metabolic might be like hereditary fructose intolerance, then congenital disorders of glycosylation. Again, that is again multi-systemic. So this is one can be there.
Okay. Sarita ma'am, what about hematology angle to this case? Can this just be a hematological problem? What is your opinion?
Yeah. So, see, primarily hematology to come with abdominal distension, considering mild ascites, I mean, we are now assuming that whatever abdominal distension was contributed by the mild ascites and whatever, some liver there. Okay. So primarily, and melena then up there. Melena with platelet count normal. Let's see what PT-APTT comes there. So if it is primarily bone marrow, platelets usually won't be spared. They are the cell lines with the shortest half-lives. Okay. So there is no primary infiltrative disease usually, which will actually first suppress the RBCs and then go, unless it is PRCA. Okay, if it is pure red cell aplasia, that is the only scenario which will first affect the RBCs and then go and affect the platelets. So still, I mean, other than malignancy is also primary hematolymphoid malignancy is out in this scenario. Okay, your platelets again being normal and the anemia being affected, your primary hematolymphoid malignancy is also out. So my first again differential with that kind of liver affected, and this is still autoimmune because some hemolysis is also going on there. Otherwise, primary hematological coming up like this LCH, yes, some variants of histiocytic disorders can cause this kind of picture, but still, if marrow, it has to be platelet always first, secondarily coming malignancy. Okay, so I would still put it second.
Perfect. So I think let's go to the next slide and find out what happened. So on examination, this child is conscious, alert. He's febrile, his heart rate is 102, his blood pressure is okay, saturation is okay, pulses are all right. And there's no icterus in this child. There's no clubbing, generalized lymphadenopathy, there's no edema. And this is the anthropometry, PG students. What is your interpretation? So you can see that the length is 80 centimeters and the weight is 10.6 kilos. Z score is less than 3, -3 lengthwise, and the weight is -2 to 0. Weight for height is 0 to +2. So what is your interpretation?
Child is severely stunted here, and weight is based on the Z score, it is on the lower aspect of normal range. The child is otherwise well grown.
Right. So based on this anthropometry, are you veering towards a liver disease or a hematological problem? Stunting will be more common in a hematological problem or a liver problem. Will it help you, the anthropometry?
Sir, I guess stunting is more towards a pointer of a hepatic, some chronic liver disease here, as
All
compared,
right.
compared to blood.
Yeah. So
Sir,
general exam,
can
nothing
you
much.
show the
Yeah,
picture,
sorry.
picture
Yeah.
of the child?
Sorry, I missed that.
Yeah, can you show the picture of the child, sir, again?
Yeah, sure.
Yeah, for the PG student, what do you think looking at the picture?
Is there a distension of abdomen or not? And anything else that you pick up on this?
This organomegaly, like there's no gross ascites, there's no ascites here, but there's abdominal, hepatomegaly and possibly splenomegaly as well.
So it has,
In the picture,
yeah,
which
sir,
Hyperpigmentation of the
yeah,
limbs.
that may be the shadow, but definitely there is a significant organomegaly. So now going back to the ultrasound, liver normal, don't buy those. Okay, always ask for the sizes. Okay, so please go ahead, sir. Sorry to
Absolutely.
interrupt.
Yeah, sure. No problem.
I'll just add
Okay,
one
so
thing here, sir.
yeah. Yeah.
For the PGs, whenever you have to interpret anthropometry in a child who has a massive organomegaly or a gross ascites, please take into consideration the weight of that fluid or organ also. And you would like to actually, especially if it's fluid and you're going to remove it or it goes down with diuretics, please interpret your take your anthropometry and interpret it again with that weight subtracted.
Absolutely. So a nephrotic child, you might feel that, he's appropriate for his weight, or a chronic liver disease with an ascites or a cardiac failure even. But mostly this is edema. And once you treat the child, the edema is going to go and you're going to get the real weight. So nothing much on the general examination. On systemic examination, the abdomen is distended, upper abdominal more. On palpation, the liver is enlarged. It is 2 centimeters palpable below the costal margin. It is firm, non-tender, smooth surface, rounded margins. The left lobe of the liver is also enlarged. And the spleen is enlarged 6.5 centimeter. It is grade 3 splenomegaly by Hackett's. It's a firm, non-tender, smooth surface, and we could appreciate the splenic notch. You can see in the picture here that you have a left lobe palpable and we have a spleen which is very easily palpable, and both of them are firm, and the liver span is 11 centimeters. So based on this, I think we can safely say that this is a hepatosplenomegaly that we know. Now I would like to ask Dr. Vibhor, what is your interpretation about the left lobe palpable? What is the importance of the left lobe really here for the PGs?
Yeah, so just let me just go through again this description. The firm, non-tender, smooth surface, rounded margin, and left lobe palpable. Smooth surface. So, okay. So, I will just like to add for the PG student about the liver examination. So, whenever we are, so palpation is firstly, of course, the sizes. When in this kind of liver, you should always mention liver enlargement at 3 points. One is right anterior axillary line, then right mid clavicular line, and also below the Zippy sternum. because it is not the regular liver, which is a normal shape liver, which is enlarged. That will tell you, okay, oh, so it should mention 3 points. Then it's a firm and non-tender. Now the surface is smooth. Now margins. So one is the margin and is the border. Okay, there is a difference between the margin and border. So or the border is what sir has drawn. So that is the border. Okay. So now we can see, we have to see how many notches you have felt. One notch is normal. So here, basically, this is one notch that you see that is basically differentiating the right lobe and the left lobe. Now, margin. So that is basically this one. And when you are saying the approaching the liver from the below, when it becomes rounded, then the liver is soft. Okay, that's why it's become rounded. If you see or if you remember the liver from your anatomy class or any book picture, so it has a very sharp leafy edge below one. When you approach while palpation, is so soft that it gets rounded. That's why you get the rounded. A firm liver cannot get rounded. Okay, so if you are saying a firm liver, then you say it's a sharp margin because you are contradicting yourself with the consistency of the liver. Okay, so the such kind of liver are generally firm. So just mention that there are a sharp margin. Okay, I think spleen is whatever sir has said, that's fine. So this is definitely, there is a left lobe enlargement. Now left lobe enlargement tells you about the chronicity, that this liver has an enlarged, and that's for significantly on a larger duration. So there is a differential enlargement of the left lobe, and also sometimes in Budd-Chiari is also the left lobe enlarges.
Perfect. So now we have established that there is a hepatosplenomegaly in this child, and the other systems are normal. There is, the respiratory and the cardiac and the other systems are normal, except that there is a grade 2 soft systolic murmur, and this we attributed to the anemia. The child had severe anemia and blood transfusion. So this we attributed to the anemia really. So at this point, PGs, what do you think? Now you have a answer? Hematology, liver.
So the liver is firm and has sharp margins. It goes more. There is a component of chronic liver disease as well here.
You feel this is a liver disease, not a hematological problem. Okay, we'll go with that. Yeah, you were saying something.
There is hepatosplenomegaly as well, and that is also sort of chronic liver disease with some beginning of, I guess, portal hypertension might be there.
So yeah, splenomegaly with a bleed, with a with a spleen palpable and a melena, you would think of portal hypertension.
The early parts might be.
Sure. Okay. All right. So most likely we say this is a chronic liver disease with a portal hypertension. So this was the provisional diagnosis that we had. Now DDs, do you agree with these DDs, Dr. Prachi ma'am? Storage, infectious, metabolic, in that order?
Storage, as I said, the only thing that we can consider clinically here is probably the GST type 4. Chronic hepatotropic viruses, if the fever had been along with the organomegaly, I could still have considered it, but this has predominantly started as an organomegaly, and very much later in the onset that fever has come up. So that's a little odd. Chronic hepatotropic, again, as Dr. Vibhor had mentioned, Hep B, Hep C, in a 2-year-old child, we would never expect them to come as a chronic liver disease with portal hypertension. They would be incidentally picked up. So I would have still expected the inflammatory etiology in our differential.
Right. So maybe some inflammatory, then a storage, then a metabolic, and then an infection. That is what you would go with.
Probably, yes.
Okay. All right. Okay. So these are the laboratory values on admission, and you can see that the blood transfusion has raised the hemoglobin to 7.7. The platelets are normal. The SGPT is still elevated. SGOT is elevated. The albumin is on the lower side. So not much change, but here you can see the INR, which is
Sorry. The MCV is, I think, typing.
No, it's printed wrong. Yeah, it is 71. Yeah.
Okay. All right.
So the INR now is elevated. It is 1.5. So with a low albumin, elevated INR, a raised SGPT, What do you think, students? What do you think, Dr. Manan?
This is in fact more. This is strong pointer towards hepatic etiology. There is a
We
component
are
of
thinking of, yeah, liver disease more than hematological problem now.
yes.
Right. So ultrasound abdomen we did again, it was the same that the liver parenchyma they thought was normal. Enlargement they saw. So they said the liver is enlarged 11.5 centimeters and splenomegaly, no free fluid in the abdomen. Okay, so now we thought, this is so much hematological involvement is there, liver involvement is there. Is there a storage we are dealing with? So we did a peripheral smear and a bone marrow. And what are these cells? I would first like to ask the PGs, what are these cells? In the peripheral smear, in the first picture on the left side, what cells are you seeing? Okay, Dr. Sarita ma'am.
It's
Hello.
so these are
Sorry.
lymphocytes.
So the arrowed cells which you can see, they are like your band cells. Okay. The income and the spicules, on the cell membrane, when you are looking at those spikes somewhere, I mean, that's not a very clear one, but they are like your acanthocytes. All right. And the one which is seen above is like a band cell. Okay.
Yeah. So the acanthocytes are very classically seen here. You can see the acanthocytes very, very well here. Okay. And then a bone marrow was also done, and that is showing erythroid depression. And there is an increased number of small lymphocytes, and there is some mild hemophagocytosis which was seen. And the impression was this is a post-infective picture on the marrow. And we were advised to do, parvo, EBV, and hepatitis viruses. These were done, and these were all negative. And liver function test we have already done. So based on this marrow, what is your thoughts, ma'am, Sarita ma'am?
If you look at the cellularity, okay, when we saw that the RBC count was low, we thought that maybe the marrow is not adequately compensating. But if you look at the cellularity of the marrow, it appears like a good reactive marrow. The precursors, though, I mean, the report is saying is mildly diminished in the erythroid cells, but if you look at it grossly, it does not seem like a primarily marrow. It looks like a secondary reactive marrow, which is compensating for everything. And yes, mild hemophagocytosis, and that is why a lot of secondary macrophages and things are seen, but it looks like a normal, good reactive cellular marrow. Primarily, bone marrow involvement is out in this case.
Right. What about the schistocytes? What is the importance of the schistocytes here?
So, schistocytes indicate that the RBCs are getting destroyed because of any mechanical stress. All right. Most commonly, it is because of a vasculitic process usually in the vessels. So here, what do we interpret those schistocytes as will be little difficult to say. I mean, what the etiology is causing schistocytes is like a vasculitis, inflammatory. There are multiple causes that can cause breakage of the cells in the line. Other than HUS, commonest scenario where we start looking for it is in TTP, which is again very less likely here.
Yeah, the clinical picture of the child is not in keeping with HUS or TTP.
Correct.
And we have a lot of schistocytes here. Dr. Vibhor, what about this bone marrow with the liver disease? Will it help?
Don't know. Here, we can't say from our.
Right.
Yeah.
Okay, so as a we suspected that this is more likely a liver disease more than a hematological problem, primary hematological problem. So what further tests would you do, Dr. Manan? Any other tests you want to do in liver for finding out what is causing the problem?
So liver biopsy. Can it
You want to
help?
do a biopsy, okay. Now remember the ultrasound did not show any portal hypertension. Portal pressures were normal. So this child has splenomegaly, likely a chronic liver disease, but there is no portal hypertension on the ultrasound. So Dr. Prachi, is it possible that the Doppler is not showing any portal hypertension?
Right. So I would still like to look at the scopy also, the OGD scopy also, because the presence of any varices there would still point towards a portal hypertension.
Perfect. So that is what we did. So I'll skip this slide. So we gave FFP, etc. So now this is the scopy picture. So we did a
Just
upper GI.
just a comment. When your platelets are normal, this child has a normal platelet. So in that
Absolutely.
situation, or bleeding related to portal hypertension is less likely. I'm not saying it cannot be, but it is a less likely. So it's either coagulopathy, or maybe we just discuss the algorithm how it can be. I think in children the history is difficult sometimes. So please go ahead, sir.
Yeah. So the INR, it never crossed 2. The maximum INR that this child had was 2.1. And he had no bleeding from the skin, no bleeding anywhere else, but a melena was there. So we did a OGD scopy, as Madam said, Dr. Prachi said, and it was reported as a ulcer which was seen in the antrum, 1 centimeter by 1 centimeter. So how common is this, ulcer in a 2-year-old as a cause for bleeding? And this child has not received any NSAIDs. He was on paracetamol. And what could be the cause? Dr. Vibor.
Yeah. So these ulcers can be the stress ulcers because they are only in the antral region. They are not, I think, fundus normal, body normal, and only antrum. And I think I don't know whether there are 1 or 2. And after how many days of bleeding this scopy was done?
Nearly 2 weeks.
Oh, that's why, because this ulcer will not explain the melena. Though ulcers are there, they are probably already in a healing stage. You can see a nice healing edge of the ulcer. Though the quality of image is not that good, probably is taken from the paper. But I cannot appreciate the depth. So this to bleed to the extent your HB has to drop, one vessel has to expose. So I'm not seeing that depth in the mucosa over here. Probably in a healing stage, and H. pylori related also can be seen in Indian scenario,
Yes.
though it's not very common. And
So
other
yeah, so
situation-
it showed, there was the biopsy report, said it is a H. pylori positive and chronic active gastritis. But as you said, this will not likely bleed so much that the hemoglobin will go to 3 gram%.
No,
The more important part, sorry.
so what I'm saying that is already in healing stage, sir. In 2
Yeah.
weeks prior, it may be to the extent that it might be bleeding, but now it's not.
Right. Right.
And
And
this
there were no
H-
varices.
sorry,
So I'm
H. pylori-
surprised that there were no varices here. So the Doppler was right, the portal pressures were okay, and there were no varices, but we found a ulcer there, which, as you said, is healing. But we were wondering if this could really cause a bleeding severe enough to cause, severe anemia and requiring a transfusion. Okay, so next we did a liver biopsy. So this is the liver biopsy. So it showed some ballooning, distended hepatocytes, and there is a glycogen accumulation which is seen. And you can see that the PAS stain is showing classical PAS positivity, which is there. So with this, I think the diagnosis is very clear. What Dr. Prachi said, that the only storage which can come at this age would be a glycogen storage disease. So that is what it turned out to be. So to confirm the diagnosis, obviously this biopsy is showing micronodular cirrhosis and features suggestive of glycogen storage disease. And then we did a exome sequencing, and that showed a pathogenic mutation in the gene, and it was confirmed that this is a GSD4. Child is currently on follow-up, and this is the child. So the child is currently on follow-up, and we are trying to get a liver transplant done for this child. So I think very interesting case. We were still wondering, is it hematology or liver? And how common is GSD4 presenting at 2 years of age and this manner? So that is what we would like to know from Dr. Prachi and Dr. Vibhor.
So it is not unknown at this age. If you look at the distribution of the metabolic diseases at various ages, usually between 1 to 5 years is what they put it as GSD type 4. The portal hypertension part of it might come a little later. That is how we were taking it a little away. But now we know that this is not portal hypertension. So it does fit into GSD type 4.
Great. So overall, thank you very much. And I think it was a great discussion. Thank you, Dr. Vibhor, Dr. Prachi, Dr. Sarita ma'am, and most importantly, our PG students who were very brave. Yeah, Dr. Veena and Dr. Manan. So it was a difficult case, but what we wanted to really, share is that sometimes on history and examination, you may get a confusion as to whether this is a liver disease, is this a hematological problem. This child, remember, was referred to a hematologist first, and he did everything. The hematologist did everything, and then he said, "This is not my case." In fact, this child was referred to a GI, gastroenterologist, and looking at the liver, feel, the gastroenterologist felt that, this is not a liver case either. So it went, it came later. So there was a lot of confusion. Liver bhi nahi hai, hemat bhi nahi hai, to kya hai? So that is what can happen. I think we need to keep our, mind open to the possibilities and then follow a rational approach, appropriate examination, very careful examination of the left lobe of the liver, and then a scopy, and then a, whole exome to diagnose it, obviously. But that clinical suspicion that this could be a liver disease is very, very important. And the INR was telling you, the SGPT that was increasing was high, a little bit high, 5 times the large, it was telling you. And the albumin that was low was also telling you. The child was stunted, that was telling you. So retrospectively, if we put everything together, this was always a liver problem more. But that is retrospective. So when we are dealing with the child at that point of time, it might not be so easy. So that is what we wanted to really highlight. Thank you very much. I think
Thank
we'll
you,
end this.
sir. Yeah, very well presented, sir, and very well
रात को तो
analyzed.
सो
Yeah,
लिया
thanks for.
से रात को पैसे मांगते
Thank you, sir.
Thank you, sir.
नींद नहीं आई
मेरे को तो क्या था, मेरी
नींद नहीं आई
टाटा स्काई